we've seen here. What is it? Do you think it's ethical that even though we've seen some transplants because they are in a younger state, even though they've tried committing suicide, that they have been giving a transplant?
Yeah, so part of that is, less the objective evidence of whether somebody needs a transplant and more of the subjective, right?
Right.
We, as humans, have a hard time saying, no, this person is young, but, they can't get an organ for X, Y, and
Right.
Z. So, that's sort of the other side of it. There's no clear black and white answer. Every time somebody is evaluated for a transplant, a lot of factors are in play, and it's often a gray area, and so that's why the committee that decides these decisions about offering a transplant are large and involve people from not only the medical care team, but also from the psychologists and also kind of ancillary services to say that yes, this person, we indeed can offer them a transplant. And at the end of the day, it's a consensus, so it's not up to one person or two people. It's a group of people who put their minds together and say, okay, we can do this.
Okay. Do you ever think when they're making this decision, a factor goes in of them thinking, okay, this person should do well, and it'll look good for the numbers?
Yeah, that's kind of the dirty side of the politics of transplant medicine. I wish I could say that doesn't happen, but there are certainly some institutions that would do that. And in particular, a lot of centers will look at certain numbers, like a certain timeout from a transplant. So, for example, you might say, what's the 1 year survival after a transplant at whatever institution. And that's important because, then the governing body that provides that institution with the authority to continue doing transplants, they'll say, well, okay, your survival after, let's say a liver transplant is pretty good, so you can keep doing them.
Got it.
If they're not good, then you get put on probation, that institution's not doing it anymore.
Got it.
So that's part of the game that some places will play. That you'll
Okay. All right, well, I appreciate you taking the time to talk with me.
Yeah.
All right. We have Crystal here, one of the other CTICU nurses, and she's going to kind of go over her own perceptions of how this unit views and tries to maintain the bioethical standards of the nurse and patient relationship when we're talking about LVADs and transplant populations. So can you talk about how, what you think as far as like when we tell patients that they're going to get these, treatments and that they're going to feel much better, and we kind of don't really tell them that we're really swapping one problem out for another.
Yeah, I think as a nurse, seeing patients time after time after they get their LVAD come back in with recurrent problems not related necessarily to the LVAD, it's hard. It kind of loses. I have lost a little bit of steam in my perception of people with LVADs because of that. They come back in for GI bleeds or high INRs, or they're immunocompromised from maybe the LVAD or maybe something else, and so they're in here because of infection possibly, and it seems as though they weren't really given the full picture when they got their LVAD at the start of their journey.
Right. So do you think that it's totally ethical when we're laying out these treatment plans? We're not really, because as you said, you don't think that they get the full picture, and one of the terms that, in the ethics realm used as framing it, as far as, making it seem like it's this one thing, but excluding, the underlying picture, as you said, not going big picture.
Yeah, I think that as as doctors, they have a unique place when speaking to a heart failure patient and they're laying out options. Obviously, an LVAD, you want to paint it in a really great picture because when it goes well, it can go really well. I've seen it go well. I saw a 70-year-old man who was diagnosed with stage D or class D, whatever, heart failure. He got a heart rate too, and he got 5 years out of it. He was able to see his grandkids a little longer, and I mean, yeah, in the end, he was in the hospital for a long time, but it did what it was supposed to do for him. So I feel like they have to put it in that light a little bit, but at the same time, once they say LVAD and once they tell a heart failure patient that they have more time, then the heart failure patient goes tunnel vision. Okay, hope. And then everything else kind of goes out the window a little bit.
Do you think less people would take these options if they knew the possibility of, I'm really not going to get more time, I'm just going to spend it in the hospital?
I think that people who are close to ICU nurses understand it a little differently, because I go home and I say, oh, I took care of this LVAD again, or this person just came back in, he was just out of the hospital, or whatever. So I think that it's a knowledge-based deficit. Like, the general population has such a medical knowledge deficit, and so they just don't even understand, like, starting basis concept. So I think if there was more understanding, maybe the true hope of an LVAD could be seen with clearer eyes instead of the way that it's seen as like a promise or like the pot of gold at the end of the rainbow kind of thing.
Right. And so one of the bioethical standards that's talked about, like when, you know, we're talking about this relationship between the healthcare and the patient, is objectivity. And that's what the understanding that both parties understand what they're getting out of the agreement. And so based on what you're saying, do you think that the patient is actually maintaining their objectivity when they're taking these treatments or agreeing to these treatments?
I think probably no, they're not keeping their objectivity, but I also think that it would be hard in their shoes to keep your objectivity when someone's dangling a carrot of hope in front of you with
right.
more time.
And I totally agree with that, and also the fact that, you know, the real hope is, and on our side it is, the hope is that they will, you know, be able to be more autonomous, maintain their freedom, and obviously we're not trying to cause them any undue harm, and unfortunately sometimes it just like happens and it's not from our end, it's just, you know, a matter of the way it goes and the science behind how this goes. And obviously every patient's different, and Dr. Mehta had talked about, unfortunately, with the transplant population, it is a numbers game of picking and choosing who they think is going to do well, because he said, if we take a bunch of people that obviously need it and they don't do well, if we have poor numbers, then UNOS is not going to let us do these transplants. So and then it's like kind of is the you know, the benefit of few, you know, or, you know, the harm of a few for the benefit of many, kind of.
Yeah. I guess sadly sometimes it's the way that the doctors and I guess all of us, the medical team, look at it as if like a numbers game a little bit, and we obviously don't want bad outcomes, because then our numbers drop or whatever, and then our status drops. And again, I don't know how to get around that, because are you going to take your grandma to a hospital that has poor outcomes? No.
Right.
You want to take your grandma to somewhere the best.
Right.
The best. You
right.
know, you want to take your family and loved ones to somewhere where they've had good numbers, but the game of how you get those good numbers is,
as Dr. Mehta said, it's kind of dirty.
Can't be entirely ethical.
Yeah. Well, thank you for participating.
Cases is that when people are faced with a surgery, they don't have anybody to talk to. They don't really know what they're getting into. And but it's kind of our job just to get them through. So, I mean, we see it all the time, and we know they're going to get better. So even though they're complaining and saying, I can't take this anymore, I'll never do this again, I feel that in a couple of days, it'll be better. The first 48 hours is probably the roughest.
So do you think that we kind of do a poor job as like making sure that patients understand what the post-op course is going to look like? We kind of tell them like, oh, you're going to get this surgery, you're going to feel great. But we don't tell them you're actually going to be in a lot of pain.
I don't think, that's kind of hard to say too.
Yeah.
I don't think anyone talks about big picture. Like, they're kind of shuffled along from step to step. Like, you might come into the clinic and, oh, we're going to put you on this medicine, and then something happens, and maybe you end up in cardiac medical ICU, and you're there for a period of time, and then you need this surgery, and then you're in the cardiac surgery ICU, but no one talks about like the big picture. There's not one physician who sits down and says, this is the step-by-step and how things are going to play out. It's just like, oh, you need this now, and then you need this, and there's no big picture talk. It's just like shoving you along from step to step.
So you don't think that we can improve on,
because they don't realize that they're going to be on anticoagulants for the rest of their life, which makes them susceptible to GI bleeding, rectal bleeding, esophageal bleeding,
Brain bleeds,
brain bleeds, possible stroke, and so a lot of that isn't hidden isn't told because they really they're in heart failure, so it's either an LVAD or palliative care.
so do you think that's ethical that they elect to, tell them after that these are the complications of these anticoagulants?
Oh, I think they tell them, but just real fast.
Okay.
It's like, here's your option or die.
right.
And it's not, no one talks to them about what palliation would look like, and I think a lot of people think palliative care is synonymous with hospice, which isn't the case. So I don't think their options are laid out clearly for them.
Okay. How do you guys feel about when you guys are taking care of someone that you guys know is going to die, and that the care is probably futile, and you just feel like you're coming into work and really all you're trying to do is just not have them die in your shift? Like, how does that make you guys feel when you guys are taking care of them? When we get into this to help people.
Even if you know it's going to end badly, you still have to do the best job you can. So there's, as a nurse, there's an ethical thing there. You can't slack off on your effort just because you know this is going to end badly.
Mm-hmm.
So you still have to do everything by procedure, by protocols, and compassionately. Because that's just what nursing is about.
Yeah. Do they make
pick and choose?
Right. Do you think it makes it more difficult, the fact of like really the patient can't even express his own wishes of, I don't want to do this?
Yeah, it's sad when when you're taking care of someone who is just in such rough shape, and you feel like, if I were in that situation, I would have absolutely no quality of life. I wouldn't want to be doing this, but there is just this part of every nurse that wants to, like Doken was saying, just try and do your best effort, make them as comfortable and make that as good as a shift for them as you can, even though you don't know if you're doing, what's
Mm-hmm.
what they would want.
Yeah. And I think it's a great point that you bring up, is the fact that we see this every day. So most of us are like, once we get to a certain age, we're probably going to sign a advance, or make sure that we have our advanced directives in order, and make sure that our families know that that is not what we would want as far as being on ECMO, not having any brain function as far as cognitively aware of something, and basically just only having your brain stem intact. But again, like I said, the general population doesn't think about that.
No, they think all medical problems
Hey guys, this is Andy just doing a post analysis of the interviews. So throughout the semester, I've been kind of just wondering, like, have I been maintaining that bioethical standards of the nurse and patient relationship? And in some aspects, I don't think that I have been, and our floor in general does need to improve on. One of the big things was that I've talked about with some of them was objectivity, and that I don't think they really understand the entire agreement that they're making when they elect to get these LVADs or transplants. I do think that we maintain the do no harm aspect of the bioethical standards, and that we are trying to make them more independent and autonomous, and increase their freedom, because a lot of the times they are just too sick to really do anything, and I think our hearts are in the good place. But what I was worried about throughout the semester was we and Doken had kind of talked about it. We kind of just tell them, okay, this is how it's going to go, this is what we have to do. There's really not an option, and that's really where the care advocacy, a theoretical framework that's illustrated in our Houston bioethical standards textbook, talks about that. We kind of, in the acute care setting, we kind of an unequal power arrangement with the patient, that they're sick and that it's our job to be their advocate, to increase their autonomy, and that's the end game. And while it may not seem like that they're maintaining it from their standpoint, that is what we go to school for, to make them better and to help them become less vulnerable. And that's really what we're trying to get at. So one of the things in the caring advocacy theoretical framework that I also want to touch base on is probably one of the hardest things to do, and that is us advocating with the family. We do a really good job of advocating with the doctors, both for the patient and for the family, but I think sometimes we when a patient's not able to make decisions for themselves, we kind of start to gravitate, at least on our unit, towards advocating with what the family wants. And really, it kind of gets lost in translation. It's really what's best for the patient. And that's something that I think sometimes we need to take a step back and be like, okay, well, maybe we need to talk with the family and make them think long and hard about what would they think their loved one would want. Okay, so one of the last things I want to talk about is something I discussed with Dr. Chris Mehta, was the transplant population, and determining between the morality that we feel of trying to help everyone that we can, despite the some of the harm that they've done unto themselves, and then the objective facts of, is this a reasonable transplant candidate. And I think it's something to be talked about as far as the moral stress that it places upon us as providers when determining whether or not these are valid transplant candidates. And hopefully, unfortunately, these people are in a vulnerable state, are moral agents that need to be helped and guided through this difficult time. And this is where the caring advocacy can kind of benefit us, because they do have such limited knowledge, as Crystal had talked about, of this healthcare-based system and these advanced therapies that are kind of glamorized in television. And talking about with these transplant candidates, I think it's important that we as providers just do the best we can as far as outlining, what their post-op course is going to look like, but then in all honesty, having an honest discussion about what the rest of their life is going to look for, so that way we can improve their objectivity when they're going into these, difficult situations of, having a transplanted organ that is not, native to their own body. And I think it's something to be said that their psychological fragility is something important when it comes to how well someone does. if we do that, then I think we can, honestly say that we've done the best that we can for our patients and making sure that, we maintain their autonomy, increase their freedom, try and make sure that no harm is done to them, and honoring our agreement that we are trying to do what's best for them. And in that fact, hopefully we can have better outcomes, and hopefully in the end it won't be about a numbers game as far as who gets what organ, and just because they're going to do well. Thanks for watching this video. Hopefully it brought some enlightening topics to mind.